sign. You will now be placed into conference. To mute your line, press *6. To unmute, press #6.
Good morning. Good morning.
Good morning. This is Charles. How are you doing?
Hey, good, Charles. How are you?
Good. We're here with all of the staff, and we have your presentation up on the screen ready to go.
All right, awesome. I'm going to go ahead and record the session, if you guys don't mind, so in case anybody of your team isn't there, that they can look at the recording a little later. Is that okay with everybody?
That's good.
And here we go. All right, so I'm going to cover cultural competency, but I'm also going to cover a little bit of the ACA. And so I'll do ACA part first. I know there's lots of questions around the Affordable Care Act, what it covers, what it doesn't cover. You all's role, you guys are fortunate as a health center to be one of the health centers that are connected with a connector entity in the state and have a role as the sisters. Beth and I were just talking yesterday about how some of your budget will flow for that. There's also quite a bit of really good progress that's going to be made with what you all can do with your application counselor, new position, and some other things. So we'll be talking about that in a second. So first, just right on into the slides. So again, I'd like to show you where I'm going before I get there. Sorry I can't be there also in person, guys. I have to be at another meeting at 10 this morning, so I can't do that. So we'll talk about the Affordable Care Act. We'll go straight into cultural competency and then some team building that's going to be built into throughout the presentation. So with the Affordable Care Act, sometimes we feel like this. I'm a little stressed out, and also just with all of the changes, you guys have a new EMR that you're implementing that you just went live with, I believe, yesterday and last week, and so there's a lot of change. Then there's PCMH, readiness, and then, of course, the 19 core requirements, and then ACA. So there's a lot of change. So sometimes we may feel like this. We want to feel like this. We want to feel really stress-free and relaxed in our workplace. That doesn't always seem to happen. So I'm going to have you guys do a few activities really, really quickly. The question is, how do we get to a place of relaxation and calm? And the big answer here is teams. So it's building and relying on each other in groups of teams so that when one person feels a little overwhelmed, that somebody else steps in and tells them it's going to be okay and reminds them why we're here in the first place, which is, of course, for our consumers. So I'm going to have you guys do a quick little activity. It's called Two Truths and a Lie. So I want you to take 2 minutes to do this exercise together. So you're going to just write down on a piece of paper 2 truths about yourself and 1 lie. And then the goal is do not reveal to anyone what you wrote down. Make 3 statements to a small group of people, or you could do this to the person to your left or your right. And you'll read the statement, and then they'll have to determine which of the statements is the lie. So 2 truths and a lie. So just take 1 minute. Go ahead and write down your 2 truths. It could be, for example, that you're a phenomenal dancer. You're from Ireland, and your maiden name is Powell. So if one of those was the lie, then the person opposite of you would have to figure out which one is the lie. Everybody understand the activity?
Yeah, Duane. We're good. We're just passing out paper.
Okay, perfect. Okay. So we're just going to give you guys a minute to do that particular activity, and then we're going to skip the second activity and go right into the presentation. But we like to do a little bit of fun activity while we're together, right? So I'll give you guys like 3 minutes to do the exercise. Take your time. No rush.
What'd you say? It's hard to fly. Think of a lie. Carrie, you know that. He never introduced himself.
Duane Taylor.
Okay, Duane, we're all finished.
It's all finished? Okay, how did the activity go, guys? How did you feel?
Well, we're all finished writing things down. You want us to pass it to the person next to us?
Actually, so what you do is you keep your statements to yourself, and then you read them to the person that's opposite of you, and they have to figure out which one is the lie. So you'll read all 3 statements, and then they'll have to figure out which one is the lie. You'll have 2 minutes for this activity, so go ahead and turn to your neighbor and start doing your activity. And sorry, guys, my name is Duane Taylor. I'm with MAC, and I'm the interim CEO. I'm also the COO and CFO here, our trade association. Go forth, do your activity. Thank you.
Okay, Duane.
Good. So how was the activity for people? Were you able to figure out who's lying, who's not?
Yes.
Good. So it's a great activity to just do. It's fun. People like it. You can always do this within your small teams. It's a really good team building or team icebreaker to do in any kind of team meeting. It's just it's a fun activity. So we would normally do this other one, Honey, I Love You. I'll explain it to you guys. You can do it post this call. So basically what you guys do is split into a group of like 4 or 3 people, And then the goal is to go as one by one, starting on your left. The person has to turn to the person that's immediately to their right and say, honey, I love you, but just can't smile. And that's the phrase that you're going to continue to say. The goal, of course, of the person that is saying, honey, I love you, but I just can't smile, is to try to get the other person to smile. Whoever smiles then becomes it, and then they have to go ahead and do honey, I love you to the next person. You can do anything but touch the person, so you can make funny faces at them. You can do really strange voices, lots of things that you can do. The only key is you can't physically touch the person, and your goal, of course, is to make the other person smile. Sometimes we take work way too seriously, and so this is a way that we can build in a little bit of fun to try to make each other smile. You'll remember this activity later on, like throughout the day or throughout the week. So you can do that activity a little later on your own. We're going to go straight into ACA overview because I want to maximize our time together. All right, so healthcare reform. So as everybody knows, there's about 29 million people that will be insured underneath healthcare reform. This is a really, it's quite wonderful. In Maryland, sorry it says in Delaware, I'll get you the correct slide. In Maryland, there's around 790,000 people that will be impacted by the ACA. Right now in the United States, there's 48 million people that are uninsured. The question is, why only 29 million will actually be impacted by the ACA? The reason there is that there are three different groups, well, there's several others, but three main groups that are excluded from the ACA. One is folks that are incarcerated. Obviously, they're getting their health care directly from the prison system, so they do not qualify for ACA. Also, people that are illegal immigrants in the United States. They do not, they're exempt from the tax, and they're also excluded from the program, meaning that they cannot receive the benefit. Now, if a person was legally in the United States on a whatever type of visa, J-1 visa, work visa, whatever, or they're in the process of getting their green card, they can go ahead and access this. There's some restrictions around it, but it's pretty specific. So why is such a big deal around healthcare reform? The biggest thing is the decrease in our gross domestic product. So right now, healthcare expenditures is the second leading cause of expenditure that the United States spends overall for our gross domestic product. Does anybody care to guess which is first before healthcare? Yeah, I'm sure you guys could guess. Of course, it's on defense. It is our number one expenditure for the United States, only second by healthcare reform. So year over year, healthcare reform has just been going increasingly over and over and up and up. It's one of the expenses that we actually can control. And so this is why healthcare reform legislation was adopted and put forth. The Congressional Budget Office estimates that we're going to save about $250 million over the first 10 years of the program, and over the next 10 years, we will save about $1.2 trillion. It's a huge overhaul. It's the last time we did something this large was when Medicare was introduced back in the early 60s. So this is a radical undertaking, and it is going to take some time. There will be lots of hiccups. We're going to try to make sure that you guys stay as informed as possible, but do note that the state of Maryland, as well as the rest of the country, are all trying to figure it all out as we speak. So you're going to see some false starts, a lot of kind of really confusing information that comes from the connector entities versus the exchanges. So just kind of stay tuned, be patient. The biggest thing is to try to be as informed as possible. So we have some tools for you to do that. Of course, the PowerPoint, which is up on your screen. I also, in this PowerPoint, off to the right, there's a thing called handouts. We created created a workbook for ACA. I'll go ahead and email that to Charles and Leonard after this presentation. It's on our website as well and on the Transformational Teams call. But it's basically a workbook for ACA, and you can use that with your patients. It has various sections for like seniors, immigrants, Medicaid population, and literally it's a tear-all book. So it's a workbook, but you should just feel free to flip to a page to learn a definition, tear that out, use that page however you can use to explain what ACA is to everybody. We'll also be working with you guys to try to conduct a town hall so that everybody is just aware, your patient population is aware of what ACA is and what the benefits are. So embedded in the ACA, there's two big premises. One is this notion of essential health benefits. These are key elements that are embedded in ACA, such as the prescription drugs, emergency services, ambulatory patient hospitalization, lab, rehabilitative, and services and devices, mental health and substance abuse, pediatric, as well as preventative and wellness. The other big thing, which of course all of you all know, is about the pre-existing condition clause that is embedded in healthcare reform, which of course is going to increase access to care. Again, it's around 750,000 people in Maryland that will become eligible for health insurance really for the first time ever underneath ACA. In terms of healthcare reform, there are basically two options. There's Medicaid expansion that a state has, as well as a healthcare exchange. Within those, the exchange portion in our state of Maryland is doing the Medicaid expansion. You all have a sister state, West Virginia, which you see some of the West Virginia folks. So there's called the federal exchange, federal partnership, which is where the federal program, the federal qualified health plans and the exchange actually happens and it is administered at the federal level, but outreach and enrollment activities are handled by the state. West Virginia has a federal partnership. Our state of Maryland has what's called a state-based exchange. West Virginia is also doing Medicaid expansion up to 138% as well as FPL, which is the highest rate that you can do. So just the distinction between a state-based exchange and a federal exchange and a federal partnership. Federal partnership, again, means the federal government, if you had a true federal exchange, the federal government does all the outreach and enrollment activities as well as the administration of the insurance plans. So you guys have heard about the application counselor role and the new dollars that you guys received in outreach and enrollment dollars. That application counselor role and why they've asked you to sign up with the federal side is in West Virginia, you have that federal partnership. So part of your administration and learning of how the system is going to work is through the federal partnership and through the federal exchange. So want to make sure you guys have registered, which I know you guys have. You may have not received your passwords or any type of training information on the federal program yet. They had a backlog. There was about 14,000 people that all went to register around the same week, and so they're a little backlog on getting people their information back. It's a 5-hour training for application counselors. Big distinction between the training that's offered by the federal government and the training that are offered by state. Our state program, as you all know, we have state navigators, and then we also have what's called assisters, and then there's a role called application counselors. Just going to go over to all three. Patient navigators, or navigators is how it's mentioned in our state. Navigators, they are people that are with connector entities. Does everybody know about the 6 connector entities? Does anybody need me to review that?
Go ahead. Duane, go ahead and explain it, please.
Sure, not a problem. All right, so what ends up happening is every state has these options to do the federal exchange, a federal partnership, or a state-based exchange. Our state Maryland chose to do a state-based exchange. What did that mean? That meant that they're going to administer the program, and they're going to have this group called Qualified Health Plans, called QHPs. QHPs are just the insurance companies that are going to participate in the state-based exchange program. On the federal side, you have federal, which are larger national organizations, again, HMOs, right, that want to participate in the exchange, which is just the insurance companies again. So United, Aetna, the normal suspects that have a national presence are people that are going to be on the federal side. We just happen to have similar folks in the state of Maryland. Now, Maryland is way ahead of most states in terms of the implementation of ACA. So we've already selected the 6 to 8 different providers groups, meaning the insurance companies, and they're going to be called qualified health plans. Each plan underneath the exchange will have various efforts that have like a silver, a platinum, and like a gold plan. The base will be the silver plan. All plans will have to offer that, which are all the same essential benefits. But think about your own personal insurance. So you choose if you want to have vision and you can opt and pay more money for vision. You choose if you want your premiums to be a little lower, or you want more specialty care, or you want to, instead of being prescribed who your PPO is by the plan, you want to be able to say, I want to go to any doctor that I can, that I want to, and it's going to be an open market. The same thing will apply here on that silver, platinum, and the gold. So those qualified health plans, again, are the insurers. So on the state side, what the state said is, we have these 750,000 people that need to get into the exchanges or into a Medicaid expansion. How are we going to do that? So they put forth a grant called a Patient Navigator Grant, and what the state did was they put up $4 million, which was, of course, matched by the federal government to some degree, not dollar for dollar. It was like 50 cents on the dollar or something like that. And these 6 connector entities were awarded in 6 different regions of the state. So they took Western Maryland and said, hey, Western Maryland, we're going to have this group. It's going to be your connected entity. Hey, Montgomery County and Prince George's County, you're going to have this connector entity. Baltimore City and the surrounding areas of Baltimore, you're going to have this connector entity. Eastern Shore, we're going to do something different for you, and so forth and so on. So those connector entities, they came together, and then they gave many grants out to different people, mostly to do with sisters. So in your area, the health department is one of the connector entities, sub-recipients of the grants. So are you all. So your role is to play as an assister. So as sisters, you're going to get a little bit of money to go and do outreach and enrollment, to bring people into the exchange and to educate them about what their options are for insurance coverage. You're also going to be charged to do some outreach and enrollment, particular in-reach at your health center, to get people that can possibly qualify for Medicaid right now with the Medicaid expansion. Our Medicaid went from, it was around 118% of federal poverty level, which was, around $9,000 and a little bit more than $8,500 something dollars, up to $14,000, which is what 138% of FPL is. So actually, here is the number. It's $15,856.20 for an individual and $32,499. So again, these connector entities then gave subcontracts out to different groups to do the activities. They could either be assisters or they could do navigation. Assisters do everything in the application process, but actually select the plan, help the people select the plan. They do everything right up until that point. Navigators, by contrast, help them navigate into a plan. They actually finish the application and push, hey, you're going to choose Aetna, or you're going to choose United, or you're going to choose whatever, and they actually submit the application. Does that distinction make sense, guys, to everybody? So I want you to hear that part first. So that's what our state did. Okay, good. All right, that's what our state did. Then the federal government, when their infinite wisdom, came out about a month and a half ago and said, we don't have enough states that are participating in a navigation and don't have enough people that are doing outreach and enrollment. How are we going to meet this huge number? I just told you 29 million people, right? How are we going to get to that number if we only have, in our state, I told you we have 750,000 people. You think you're going to be able to do that with $4 million? Really? It's not enough money. So the federal government came up with this outreach and enrollment dollars, which was a supplement to all the health centers, but other programs also received outreach and enrollment dollars, not just health centers. Our health centers did receive specific dollars, which allows you to hire a new person, that allows you to pay for outreach and enrollment trainings that the state may offer later on. So that those dollars are federal dollars. So now our state in Maryland we now had to come up with, okay, we need to do application counselors, which is what the federal government is funding. How are we going to do that if we already have a navigator program and an assister program that we've already had training dates for? Now we have to go and create a new training program for these application counselors. Application counselors, by the definition of what was provided by the federal government, can do exactly the same thing as a navigator. So you can go all the way from outreach to enrollment, all the way through the pipeline, which is great, right? So the question is, what does that mean for us? So how do we get there, and what are we going to do? Sorry, guys, my little cursor got a little crazy there. So how are we going to do that? So the federal government gave us this money. The state is in the process, which is why all the crazy with the training guys is happening. They are just having to finalize the regs because the federal regs came out, which then our state has to create their own regs for the application counselor, and then they have to create the program. So we already have the schedule for the sister program, which starts on the 3rd of September. We also have the schedule for the navigators. Again, these are state certifications. To actually do navigation and assister, you have to get certified by the state. Now they're coming up with the application counselor program, and the application counselors will also have to be certified by the state because we're a state-based exchange. Everybody follow that logic?
Yes.
Good. All right. So in West Virginia, slightly different. It's a federal partnership. So although the exchange is all happening at the federal level, but all the outreach efforts are going to happen through a coordinated effort in the state of West Virginia. So I'll do another call with the team, with the West Virginia PCA, just to go into more detail around West Virginia's ACA. They will be basically doing a similar process, but you'll learn around the federal government's application counselor process because that's the exchange that you're putting people into. You'll still do outreach and enrollment, but there's Medicaid expansion in West Virginia, and we'll need to be trained a little bit on their application process. Is it going to be different? Is it going to be integrated? What's going to change? In our state, we're really pushing people to get people into the PAC program now before December 1st, because that's when January 1st everybody should be in the exchange. Our state and as well as West Virginia, they're going to be doing outreach activities and allowing people to apply into the program all the way through March. So from October 1st is the go-live date, and it goes through March to do enrollment. There'll be a second wave of enrollment that will happen probably next September, but this is going to be our first big push-out for enrollment. So, of course, the main goals of any questions anybody has at this point?
I think we're good.
Okay, great. So just again, the main goals, of course, for ACA is to expand health insurance coverage, improve coverage for health insurance for folks, improve access to quality care, controlling rising health care costs. So the expansion of Medicaid is to individuals that are underneath the age of 65, with incomes up to 138%. Both West Virginia and Maryland are doing this. So it just took that number from maybe around $9,000, which was what we had around 118% of FPL, up to this $15,856.20 for an individual and a family of four. It's around $32,999. Why is that number important? That number is the beginning number. So the ending number for Medicaid is the beginning number for the exchange. So the exchange goes from 138% of poverty all the way up to 400% of poverty. So people can make up to $45,000, almost $46,000, and be able to get some kind of form of subsidy or premium. So, of course, the great part of the program is to incentivize people to get insurance is that the folks that are the lower income people will get a greater subsidy. So there's a thing called a tax calculator or a benefit calculator. It's on the Kaiser Family Foundation site, so I'm going to just give you the site, and we have this all in our group sites, but I'm just going to give the site to you now. If you go to www.kff.org, which starts for Kaiser Family Foundation, Kaiser Family Foundation, just type in healthcare reform, right on the first page of the healthcare reform on the left-hand side, you'll see what's called a MAGI or MAGI, just depends on who you're talking to, a MAGI calculator. That calculator will allow you to put in somebody's income, and then it will share with you what their possible premium that the federal government will pick up. So literally, the federal government is paying for people to have insurance. Literally. That's what they're doing. So if say your premium, you make $16,000 a year, you're most likely going to pay nothing. You're going to get 100%. Say you made $42,000 a year. Your subsidy, say the total cost for your premium per month, say it's $500. The federal government may give you a check for $250 per month, and then, of course, they'll annualize it and say this is what you're going to pay. So it really does reduce people's health insurance expenditures almost by half. This is a huge, huge deal, guys, because it's connected with your taxes. So at the end of the year, when you know how you get a deduction back, so you get a refund, and you have to file your taxes, before, obviously, the 15th. So what will happen going forward is that you will have to give some kind of attestation that I have insurance, which will come in the form of a letter from your insurance carrier that says you do indeed have insurance. Unlike our taxes where we have to wait for the refund, what the federal government is doing is when people sign up for the insurance, at that same time, they're actually going to be able to get their subsidy at that time. Now, there's going to be some hiccups because you're thinking, well, how are the people going to be paying a premium, right? How, are they doing like a debit card? Is it once a month? How is that going to actually happen? There probably will be some kind of debit card payment, but the most important thing is that real-time application of that saving happens at the time of enrolling. Now, again, the FPL chart is here. I can send you guys another chart that's just a Word document that may be easier to read than this, but you can see, you guys do this all the time, the social workers and the folks that help people get into whatever program. That you just figure out your family size, you go over the chart, it says 70 whatever, and then that's the number that you punch into the calculator for the MAGI or MAGI, and it will tell you what the potential subsidy would be for that family in terms of premiums. Again, Maryland and West Virginia are expanding Medicaid coverage up to 138. Again, if you have Medicaid, it's an enhanced Medicaid package now. Lots of new services are in there for Medicaid. Again, it's going to provide greater access. Here's just some numbers on our Medicaid expansion in our state by 2020. It's about 190,000 new individuals that will be able to be eligible between now and 2020 in terms of Medicaid expansion. In Garrett County specifically enrollment numbers, so folks that have income of less than 138%, which will be that Medicaid population that I just talked about, that's about 771 people. In the state of Maryland, it's about 104,299 people. In the exchanges between the 138% and 400% of FPL, that's around 665 people. Over 400, because you can be in the exchange even if you're over 400. It's about an estimate of 167. So your total enrollment number in either a Medicaid product or the exchange is around 1,603 for total enrollment in 2014 for Garrett County. This next slide does the same thing for 2015. In terms of the exchange portal, it's going to be a web-based portal. They're going to integrate the Medicaid application, the CHIP application, and the exchange application all in one application. So everything can all happen over the phone. Over the web. One of the biggest things is, how we do a Medicaid certification and research to make sure that the person still is eligible, and if they have an income justification or any type of change in their income, they lose their job. What the whole goal of doing a one-stop shop within the state is that if a person was eligible for Medicaid today and then they get a job, and that job pushes their income up to, say, from $12,000 or $11,000 to now or $12,000, they're now going to make, say, $28,000. they can automatically kind of be bumped into an exchange product. Of course, they would have to select the product and all that, but the notification would be automatic. And so you could see that, and when they come in for care, you could say, oh, so your income, you got a job, congratulations, that's awesome. Let's go into the system and update you, and then you're going to have to select which insurance product do you want to have. So that's kind of a really good thing within the navigation system. So there's going to be a web portal for consumers, and then there'll be a separate web portal for businesses. Businesses, there's another year reprieve before we really have to deal with all of the businesses. But for our purposes, for consumers, we have till October 1st is the start date of outreach and enrollment activities. And again, it will go through March. So we've already talked a little bit about the consumer assistance. We talked about the marketplace assisters already, and we also talked about the health center outreach and enrollment process. We have that in-person assisters training. I'm trying to see if the state of Delaware also has a similar program, so that if you guys are eligible to can go to that we get you guys over to their sister program too, so at least you could be cross-trained in our state program as well as the program that's over in West Virginia. Of course, you'll do the 5 hours of training for the application counselors online, and I would encourage everybody that's going to be doing any of the outreach or the enrollment sections, if it's 3 or 4 people at the health center, that all those folks get trained, and then let those people do train the trainer back to the rest of the team, the entire team, because people will ask you, regardless of if your role is to do the outreach and enrollment. They may be asking a doctor, hey, so what about this health insurance program, or they may ask a social worker or a nurse when they're getting services, hey, so what should I be doing with this? Of course, you're going to direct them to your staff member and your team member that's at the shop that does that, but I think you should have a good general working knowledge of all of that. Does that make sense to everybody?
Yes.
Okay, any questions around our ACA stuff before we move briefly into, we're going to do a bridge conversation about cultural competency, but you'll get the gist.
Duane, there's one question regarding changes in income. Is there a certain period of time by which an individual has to report a change in income to us so that we can change them from a Medicaid to a health plan?
Yeah, what we're going to encourage people to do is to tell us as quickly as possible. In terms of practice, I think they're going to have like a 30-day, 30 days, it's going to be 30 or 60 days post you finding out you had a change in income that you need to report that information so that you can change your status within the system. At the assister and the navigator trainings that are coming up next week, I think it's an appropriate place to ask that particular question so you can get the direct answer from Maryland's folks that are going to be training on the assister program. I will go ahead and write Tequila and Leslie that question because I think it's a great question. I just know that they're going to have specific regs. They also will have specific regs around the time period by which you have to change plans. So say, for example, a person chooses the plan, and then they're like, oh, I don't like that plan after 3 months. Well, can they just go change it? How will that work? And it's a process. And so I'm pretty sure what they're going to do is hold people for at least a 6-month to 9-month period of time where you can't make any changes. It's kind of like our open enrollment with your own insurance, right? So you choose a product and you have to stay with that product for this long period of time before you can switch products. The same thing will apply here, largely because your premium will vary based on the carrier, also based on the plan that you choose. Other questions?
Anything else?
Okay, so 2 questions back to you guys. Do you believe culture will impact the enrollment efforts relative to the ACA? That's the first question. And the second question, how do we assist overcoming barriers to access enrollment for various cultures? Now, where you all are, it's a little bit homogenous, but you still have quite a few seniors, which is a kind of a special population up there. You also have other groups like folks that are in West Virginia, which is very different from Maryland culture. Do you guys think that culture plays an impact on the enrollment and how you're going to do the enrollment for people?
Yes.
Yeah, and how do you think we could assist in overcoming some of those barriers? Well, let's talk about what barriers culturally do you think are going to happen with ACA? Do you think you have to do a tiered approach for outreach or just the same approach for everybody?
It can't be the same approach for everyone because we have different education levels. That's one of the biggest things. We have people that politically might oppose the ACA. We have people that supported against it. So there's all kinds of people coming in saying, I don't want it, it's welfare. And then we have people who just truly don't understand the process. So we're going to have a lot of barriers that we're going to have to overcome.
Absolutely. Other thoughts?
We want you to fix it for us, Duane.
You want me to fix it? So, thank you. So I think what we need to do is create a good strategy for Mount Laurel to stratify the population and then give each person or each group of people kind of what they need to hear, right? So regardless of people's political affiliation, which is why many people think healthcare sucks or healthcare reform sucks because it's Obamacare, right? It's not going to help. It's his presidency, and he's trying to push this Democratic agenda down our throats. And that's from the Republican standpoint, right? So they oppose it just because it's a Democratic concept. And they kind of forget that Massachusetts Governor Romney, of course, did this successfully in Massachusetts, which is largely based on our new healthcare reform. Is based a lot of what Massachusetts model did. So I think it's coming up with a stratified strategy for how we're going to educate the different groups. Also, I think it is hosting various educational sessions inside the health center and outside the health center. So maybe doing something at the local library, maybe for a seniors club or seniors group. Even though seniors are not they're kind of excluded from the ACA, there are a lot of benefits because of ACA that went over to Medicare. For example, the preventative screenings were pretty limited under Medicare before. Because of ACA, they've enhanced the Medicare benefit for what preventative screenings can happen. Most seniors don't know that. So that's a really great thing to educate them around, but they also may be talking to their loved ones who are taking them to the doctor that may qualify for ACA or for Medicaid Expansion. So there's a role of educating the consumer so that they can educate others. And so I think coming up with a good strategy that way would help us. I think there's also some outreach versus inreach. We have a lot of patients that are still uninsured, but they qualify for Medicaid or will qualify for Medicaid now that the income level for FPL has increased. What is our in-reach strategy? Maybe we need to pull down through our billing software all those that were either on a sliding fee scale or were truly uninsured in the last year, and then target those patients to go after them as an in-reach strategy. That way, we can go ahead and make sure that they're getting into PAC or they're getting whatever they can get into as quickly as we can, and that becomes our target audience while we're simultaneously doing some of the outreach in the community. So we'll work as a group to kind of come up with what that strategy looks like and then kind of implement it. And also just in terms of that strategy, we really will need to think about how the culture, again, changes. So you mentioned that, it's literacy level, it's beliefs, it's values, it's income. All those are all part of what makes up somebody's culture. Largely times when we think about culture, we think about race first. Yeah, race is one of the barriers or one of the criteria that create their culture, but it's also geography, right? So if you were born in Garrett County, there's a whole kind of thing that happens because you're born in Garrett County, right? As opposed to being an outsider. You were born in another state or you were born in another place in Maryland. It's a closed community up there, so many people see that as not just a badge of honor, but it's also indicative of how people think. And so we want to think about culture, particularly in Garrett County, of what all makes up our culture here. It's not that just everybody, or maybe 85% of the population is Caucasian. That doesn't make up the culture by in and of itself, right? There's lots more stratification. So we got to think through that. I think one of the other things is this is a cultural framework. So it's race, ethnicity, gender, age, generation, communication, languages, literacy, reading levels, if people speak another language, those are all types of things, educational level, functional as well as actual, economic status, also plays occupation. You guys have a lot of retirees. People come there to retire. So that gives you a different kind of dynamic in terms of how you have to talk to another type of group of people. And then, of course, geography, neighborhood, place of birth, legal status, travel, nationality. All those things are all part of your cultural framework. So I would like you guys to do just a quick exercise for me. So I'm going to take about 30 seconds. And then we're going to have about 15 minutes left to do the cultural portion. And then we're going to, I'll break it in where we can ask some questions. So just maybe 10 minutes. So here's the activity. I'd like you to write down 5 framework describing the culture you think is in Garrett County. Just 5 characteristic traits. It could be race, age, educational level. It could be any of these things that are stratified here, but I want you to write them down, and I want to see how close we are to each other's opinion of what culture means in Garrett County. Let's take 2 minutes for the exercise. Everybody understand the exercise?
Yes. Yes.
Great. You're just writing down a word. It doesn't have to be a phrase, just a word. At least 5 of them, please. Thank you. One more minute. All right, let me hear from you guys. What is culture looking like in Garrett County?
Religion.
Religion. What kind of religion specifically is the dominant religion there? Christianity. Okay. Others?
There are also other populations of Jehovah's Witnesses and Mennonite and Amish that may have some objections to the HCA.
Mennonites and Amish. Okay. Good to know. So we may need to think about what that means for that population, right? In terms of our larger strategy, these are things that we'll take into account. Other characteristics.
Anybody else?
Education, income.
Income, okay. Age. All right. That's a big one.
Education.
Another biggie. Unemployment. Y'all are getting there. Other things.
We have a lot of seasonal employment.
You have a lot of, I'm sorry?
Seasonal employment, people that work part of the year, but they don't work the rest of the year.
Yeah, a lot of migrant population. Okay.
No, that's season related.
Oh, season related. Seasonal work. Okay. So we may need to think about, well, when is open enrollment? When is it important to them, right? Or how does it impact them as they may be moving throughout the season based off of work? So how does that?
They stay here, but they might work at the ski resort like 3 months of the year. They may do carpentry or something 3 months of the year, and the rest of the year they may be unemployed.
I see. So then again, that would be a factor that we need to take into consideration about the change in status, right? In terms of maybe they are Medicaid now. During the season of skiing, they're going to go way up in terms of income. So then getting ready for them to change, and that might be like tomorrow. Like as soon as our open enrollment starts on October 1, you may have all these people into Medicaid. You may need to flag those people though, because you're asking the question during the winter season: do you work at such and such, or do you have seasonal work? And then they say yes. Then that may be your trigger. So in December, could you come on back in as soon as you get that job, so that we can go ahead and make sure that you're good to go and get you into an exchange product? That make sense?
Yes.
Any other factors that anybody else wants to articulate? Characteristics of culture.
Duane, we touched on this lightly before. Political party or political views. Our county is comprised of between 80 and 90% Republican, and then a small percentage of Democrats. So there's been some tension there. Our newspaper is called the Republican.
Yeah, so again, it will be a lot around just educating around, not so much emphasizing this is healthcare reform, I want to shove it down your throat, but more of this is an opportunity for our most marginalized to receive healthcare coverage, right, to get insurance, which, of course, saves us, your whole entire system of Garrett County, money at the end of the day. There's less ER visits. There's more preventative screenings that people can have. So that kind of general information, really staying away from any terms that, like Obamacare, anything that would be a politically charged term, would be a good thing to do. And that may really shape how you do your town halls and things like that. Thank you so much for that. Great job, everybody. So in addition to the cultural framework, you know, gender becomes an issue. Sex and sexual orientation becomes an issue because there may be some specific outreach we can do by women's auxiliary or involving the GLBT community, or folks that you might have a big ski group, and so you partner with the ski lodge to do some sessions up there for enrollment. I'm not sure, but there's lots of ways to think about strategies for outreach enrollment that are stratified by culture. So again, culture is all of these things. It's the religious, political, it's spirituality, ethics, values, all these things, as well as the individual things that make up a person. So maybe a person has hobbies, they're a biker, and so they really consider being a biker as a part of their identity. And so when we think about diversity, there's an inner circle factors and the outer circle. So the inner circle factors are things like age, sexual orientation, race, gender, ethnicity, mental, and physical. The outer exterior is all these other factors like socioeconomic status, communication style, work style, marital status, work background, thinking style, geographic, parental status, education, political. All those are the external things that are at the outer circle. So if we think about not just think about stratifying any type of strategies, even our strategies, how we communicate to groups to just get them into the health centers for basic care, we should be thinking about, should we have a group that's something for seniors specifically? If we see more seniors, maybe we need to have something for seniors talking about how do you take care of managing all the pills. So just doing a pill box demonstration just with seniors and utilizing M&Ms or Skittles or whatever. Quite frankly, you could do like the regular medicine for them would be great, but maybe it's their caregiver that needs that information, not the senior. So I've seen this happen oftentimes. The people will have a support group for children of senior parents, and so they go in and they have to sit in like a 1-hour presentation where they're described all these different medications. But really, at the end of the day, what you do is you take Skittles or M&Ms or whatever you want to use that's multicolors, and you give them a pill box, and you explain to them all the blue M&Ms represent, I don't know, some pill that seniors need to take. Maybe it's heart medicine. This other one is for stroke. This other one is for diabetes. And I want you to, just for this day, follow this prescription. Every 2 hours, you need to take the blue pill. Every 1 hour, you need to take this. This you'll take with food. This one will take with milk. This one you have to take on an empty stomach. And that's what you have to be able to teach to your senior, to your parent, or manage for them. And this is all the things that will help them be a better caregiver to that senior. But thinking about how you do some of your programming that stratifies by this inner circle as well as the outer circle can help you make a huge difference in terms of treatment adherence and people really becoming compliant with their medication. Some of the culture that we have in Western Maryland, Western medicine in general, is foreign to some groups of people. They just don't believe it. They're like, it's part of obviously the dominant culture in the United States, but you may have people from other places that really believe in herbal medicine or they believe in acupuncture. And it doesn't mean that it's less valid than our Western medicine. Of course, we're going to try to steer them to following whatever we prescribe, but I think being open to, if they're saying, because of my religion, I can't do X, Amish might be an example of this. We don't believe in, you talking about sexual orientation or about birth control or any of that to our children. So what else can we talk about that is going to help make sure that we're talking about overall health care conditions that are not offensive to a particular group of people? That's a part of culture, and being sensitive to that is a really huge thing. So why do we want to participate in some kind of cultural trainings? Understanding, accepting, and working skills. So within your health center, I want you guys to do one more exercise for me right now. I want you to write 3 different things that describe your culture as an individual. Can you do that for me now? You just have 1 minute, and I just want one word. And it can be however you define your own culture, not anything that I've said so far, but however you define yourself as a person. Some people might write mother, friend, coworker. Other people might write Caucasian, Baptist, whatever. Just 3 things. $30 seconds. So can some people just read off some of the things that they said?
Go ahead, Leonard. Wife.
Wife. Awesome.
Okay.
Caregiver.
Others? Just read one. Caregiver. Friend. That's great. Heard somebody say something, but it wasn't clear.
Christian.
Christian. Great. So, if we know we have all this diversity right within our health center, how can we honor and better respect each other more? You guys are already a dynamic team, but how can we really revel in somebody else's culture? What kind of activities could we do to be more sensitive, to learn more about somebody else's culture? What could we do? You guys want a hint?
Sure.
So one is, you guys do potlucks at the health center?
Once a week.
For the employees.
You guys are forever doing a potluck. So next time you do a potluck, make it really specific. Ask people to make a dish that they grew up with, that your mom made for you or your dad made for you. Make that dish and explain significantly. Oh, there you go. But explain it. So why was that a staple? Why was that so important for your parents to make for you? And that will give you an insight into that person's, not just their childhood, their upbringing, but it also will probably reveal something about the culture. So if you're Irish and you grew up on Irish stew, and that's what you make, because your mom made it, and her mom made it for her, and her mom made it for her, and it's a third generation, passed down recipe that speaks to your culture, that's a great thing to explain a little bit about not just the dish, but around the relevance of your culture to that dish. It's a great way for people to see each other in a different light. Of course, we're in culture or culture competency, a lot of culture competency is, not just understanding somebody else's perspective of culture. That is the basic tenet of culture competency. So if I am an African-American person and I really want us to understand Irish culture, I want to do two things. One, I want to acknowledge that I don't know enough about Irish culture, right? So I want to ask you in a non-offensive way, can you talk to me about your culture? Help me understand it more. Why is, St. Patrick's Day so sacred to you? What are the things do you do to celebrate your culture throughout the year outside of St. Patrick's Day, right? Because I'm sure it's not just St. Patrick's Day. It just happens to be what we recognize here in the United States as one day that talks about Irish Americans. So that's one way. Cultural intelligence is a little bit beyond culture competency, and that's where we take it one step further. So it's not just me wanting to understand, it's but me practicing sensitivity to understanding your culture. So that means I'm not just asking the question, I'm asking how can I show up better so that I can support your culture. Oftentimes I see this, you guys don't have as much of this because of where you're located, but if you had folks that came in because migrant workers, for example, and they're from another place, they're from Guatemala or Mexico or whatever, and we don't take the time to ask, well, you're trying to get to somebody to get on a diet to, stabilize their weight. And so we'd say, you need to just take carbs out of your diet, try to eat more green vegetables, try to eat more leafy stuff, try to eat some fruits as well. But beans and rice is a staple of their diet, and it's cheap, and it's what they eat every day. So do you think that's going to change because you said go on a diet? Probably not. So what else could we ask them to do? Because they're not going to change beans and rice. Add a salad to your beans and rice. Or maybe try to take vegetarian beans. Or try to beans that are not cooked with any type of pork or fat or anything like that. That might be something that we can talk about. But it's being sensitive to that other person's culture of how they're going to change in terms of their behavior change. All right? So unfortunately, we're at around 9:19, so I'm just going to describe this really quickly, and then we're going to have to stop because I know you guys got to get back to work because you're going to be seeing patients like in 1 second. So this is what's called the Cultural Competency Continuum. Of course, at the bottom is cultural destructiveness. This is when we have a lot of biases and opinions. Now, I think one of the things that people lie to themselves about is that none of us are biased in any kind of way relative to race or culture. Of course we have biases. We have all kinds of assumptions and all kinds of things because we grew up with lots of people that had those assumptions. It changed those over time, but some basic assumptions are still there. Not because, we wanted to be bigoted, but it's because we just may not be aware because we've never been around a group of people that look like a particular group or not. So that's what's called cultural destructiveness. We don't want to continue a bias or some kind of, opinion that is truly destructive. Then we get into cultural incapacity. That means you just don't have a dearth of information around that culture. Cultural blindness is to say that I don't see any race, I don't see culture at all, I don't think any of that is relevant. I just see people. Well, if you see the people, then you see the culture, if you're really looking, right? Because nobody's without a race, nobody's without some kind of culture. Culture pre-competence is your openness to understand that I probably need to know more about a culture. Cultural competence is I'm willing to take the step to learn more about another person's culture. Cultural proficiency is I'm not just going to take the step to learn, but I'm going to actively, on my own, take more steps to be more sensitive to other people's culture. And so this is what's called a cultural competency continuum. You're always trying to move up the ladder and get to cultural proficiency. That's where we want to end up. Right now, you might be right at cultural competency. You want to learn about other people's cultures. How many of you, and I can't see you directly, but in the room, just by show of hands, how many people, like when you're going to a destination, say you're going to Mexico, that you actually go and start doing some research on Mexico before you actually get on the plane? If it's, just raise your hand, and then I'm going to ask Charles if it's more than 50% of the room.
It is.
It is. That's great. That means you guys are way into the cultural competency stage, and you're getting to cultural proficiency. You're actively trying to learn more about whatever population you're going to go be with or go visit. That's all the time we have. There's a lot more in these slides. You'll have the slides right with you. If you want, I can do a part 2 because we didn't get into some of the intricacies only because we were a little rushed on time here. But we can do that too if you guys would like a part 2 that kind of goes into more in depth. But before we leave, I want to ask people, is there anything about culture that right now you really just, like a burning question, like, I really want to understand blah? And then I'm going to point you in the direction of a really good tool that I'm going to send out to the health center. Hearing no burning questions. There is a guy named Dr. Larry Purnell, and he came up with this wonderful thing called the Purnell model or the Purnell wheel. And what it is, he's a nurse by training, and he focuses on cultural competency. And he's created this book that's used all throughout the world on race and ethnicity and culture. And so what it does, which is, I think was really, really kind of interesting, is he goes and looks at some general norms of culture throughout the world. So he'll say, if a person's from Japan and you're a caregiver for that person, here are some things that you might want to know. You might want to know that in the culture, on Japanese culture, if you're talking to a woman without a man in the room, a particular husband, it's inappropriate. They'll do the same thing for Guatemala, China, Paraguay, Haiti, all these different cultures. So it's a really kind of cool book, and you can kind of use it as a quick reference guide. So I'm going to give you guys about 5 of those, but it's amazing how accurate it is. But he spent a lot of time and effort to make the book as accurate as possible. They just came out with the newest edition, and that's the edition I'll get for you guys. But you might find it just interesting and fascinating to look at how people view pregnancy, people view communication, people view, just basic diet and exercise, if that's important to that culture or it's not important at all. Who is the best person to talk to if you want to get your message across for a health message? Should you be talking to the wife directly or the male, the husband, or if that's even a factor within that particular culture? So I just thought it was a great resource. We've used it over the years for several of the health centers, and I'd like to give that to you guys as a resource. So thank you all so much for your time and your attention. I'm sorry, again, I couldn't be there in person, but I'm happy to help. I look forward to working with you guys on your strategy for outreach and inreach around ACA. Thanks again. Take care. Bye-bye, everybody. And I'll go ahead and record this.